Welcome to episode 28 of the Pro PA podcast. I'm your host, Prof. G. In today's episode, we're building on our last topic of obstructive sleep apnea and diving into its very close relative, Obesity Hypoventilation Syndrome, or OHS for short. OHS is a lesser known but critical condition that's important to recognize, especially in obese patients with chronic hypoventilation. We'll break down what causes it, how to identify it, and how it's managed, all while keeping it concise and high yield. Let's get started. First, let's look at the kinder patho. What is obesity hypoventilation syndrome? Well, obesity hypoventilation syndrome, or OHS, also known as Pickwickian syndrome, is a disorder characterized by chronic hypoventilation in obese patients, leading to hypercapnia, which is elevated CO2 levels, during wakefulness. The exact cause isn't fully understood, but OHS is thought to result from obesity related mechanical changes. So, that excess weight that obese patients carry reduces the chest wall compliance and increases the work of breathing. So they have impaired ventilatory drive. So it's blunted respiratory response to those high CO2 levels. They also have a lot of coexisting obstructive sleep apnea, which is present in about 90% of OHS patients, which further worsens gas exchange at night. So I like to think of OHS as kind of the twin to OSA, but during the wakeful hours. And it focuses a little bit more on just not breathing as much and as deep and retaining some CO2. And this combination causes daytime hypercapnia. So that's a PaCO2 of greater than 45, and hypoxemia, which is low O2 levels. And this leads to chronic respiratory failure. So, a fun fact, Pickwickian syndrome, the name Pickwickian actually comes from a Charles Dickens paper called the Pickwickian Papers. And there was a character named Joe, or Fat Joe, in this series where he described them as an overweight character. And so, when they discovered this OHS, they actually initially kind of named it after that Charles Dickens character, Pickwickian. So the character wasn't Pickwickian, but the papers were, the character was in that paper. So I just thought that was a quick fun fact to know where that name came from. So risk factors: obesity, BMI greater than 30, especially greater than 40, which is considered morbid obesity. This is the single greatest risk factor. Now, remember, we're probably going to see some coexisting obstructive sleep apnea. The vast majority of these patients with OHS also have OSA. They have reduced ventilatory drive, so some patients have diminished ability to compensate for this hypoventilation. So we see this more often in the male sex and patients with an age greater than 50 years, and these are both associated with an increased risk of OHS. So, how do these patients typically present? Well, it's very similar to the symptoms that we saw with obstructive sleep apnea. So, they have daytime symptoms of hypercapnia and hypoxemia, which typically manifest as morning headaches from that elevated CO2 during sleep. They have excessive daytime sleepiness and fatigue, poor concentration or memory. Now, the nighttime symptoms are going to be very similar. So, snoring, choking, or gasping during sleep, very similar to OSA. They also have a lot of restless sleep and frequent awakenings. Now, on physical exam, we're going to expect to see a patient who is obese. So we typically see this in BMI greater than 30. We're going to see signs of chronic hypoxemia. So we can actually see cyanosis or clubbing in severe cases, clubbing of the fingernails. We can also see pulmonary hypertension. So with pulmonary hypertension, as we mentioned in our pulmonary hypertension episode, we see elevated JVP, we can see lower extremity edema, or even right-sided heart failure, which we would call cor pulmonale in this case. So how do we diagnose OHS? Well, the diagnosis requires obesity greater than or equal to a BMI of 30. They're going to have daytime hypercapnia, so a PaCO2 of greater than 45 on an ABG. And you're going to have to exclude other causes of hypoventilation, other lung diseases like COPD or restrictive lung disease or some sort of neuromuscular disorder. A key diagnostic tool is going to be the arterial blood gas or ABG. This is going to confirm that hypercapnia we were talking about. It'll also look for the hypoxemia, which we're going to expect to see a PaO2 of less than 70. We also want to do a polysomnography or sleep study because these patients are at a little bit higher risk. We probably want to bring them into the facility to have this polysomnography done, and it will probably identify that coexisting OSA and evaluate nocturnal hypoventilation. We also probably want to do a chest x-ray or some sort of CT scan, and this will help us rule out other causes of hypoventilation, such as COPD or interstitial lung disease. Because remember, OHS is a diagnosis kind of exclusion. Now, how do we manage this? Well, lifestyle modifications are going to be the first thing that we're going to recommend. Weight loss is the cornerstone of treatment and the only definitive cure for OHS. Now, even modest weight loss can significantly improve symptoms. And we also want to encourage smoking cessation if this is applicable to our patients. We want to suggest some non invasive ventilation as first line treatment for most patients. This is going to be BiPAP, so bi-level positive airway pressure, which improves ventilation by reducing those CO2 levels and increasing oxygenation. We can also consider CPAP if OSA is the primary issue, but most OHS patients benefit more from BiPAP. We can also suggest oxygen therapy, so supplemental oxygen may be needed for those patients with persistent hypoxemia, but always combined with ventilation support to avoid worsening hypercapnia. We also want to manage comorbidities, so we want to treat associated conditions like pulmonary hypertension or right-sided heart failure like cor pulmonale. Now, we do have some surgical options. There's bariatric surgery that we can offer for patients with morbid obesity who have a lot of difficulty achieving weight loss through lifestyle changes alone. And of course, nowadays, we have the GLP-1s that have been approved for morbid obesity and obesity that we could consider initiating, but definitely want to provide the patient with all the support they need to overcome and achieve the success with weight loss. Now, some complications of untreated OHS are going to be those cardiovascular complications that we talked about. So, pulmonary hypertension, right sided heart failure, presenting as cor pulmonale, increased risk of myocardial infarction and stroke. We also can see respiratory failure with chronic hypoxemia and hypercapnia, and this can lead to worsening respiratory acidosis and decompensation. We also see really reduced quality of life. So, poor sleep, excessive fatigue, inability to perform daily activities can affect their personal and professional lives. So, let's look at the book med versus the street med. So, book med is going to emphasize weight loss as a definitive treatment for OHS and BiPAP as first line for chronic hypercapnia. It's also going to recommend the polysomnography to look for OSA. Now, street med, in real world, compliance with BiPAP is really challenging for some patients. They may struggle with the discomfort of the mask fit, or they might require close follow up for troubleshooting and assistance. And also, many patients only seek care after they've developed complications like cor pulmonale. So, it's really important to educate high risk individuals early. And as we know, we have an epidemic of obesity, especially in the United States. So, it's something that we can address and identify early and try to prevent these complications from happening. Now, some quick clinical pearls to wrap this up. Think OHS in any obese patient with chronic daytime hypercapnia, especially if they have coexisting OSA. Remember, BiPAP is preferred over CPAP in OHS because it improves both oxygenation and ventilation. Weight loss, even modest amounts, can be key in improving symptoms and long term outcomes. Always check an ABG in patients with suspected OHS to confirm hypercapnia. And last but not least, avoid prescribing oxygen alone without ventilation support. It can worsen their hypercapnia. All right, now let's do a quick knowledge check. So, first off, we have a 52-year-old female with a BMI of 44 who presents with fatigue, morning headaches, and daytime sleepiness. An ABG reveals a PaCO2 of 50 and a PaO2 of 65. Polysomnography confirms OSA. What is the best initial treatment? Is it A, weight loss and lifestyle modifications, B, BiPAP therapy, C, oxygen therapy alone, or D, bariatric surgery? I'll give you a few seconds. If you said B, BiPAP therapy, you are correct. BiPAP is the first line treatment for OHS as it improves ventilation, reduces CO2 levels, and addresses nocturnal hypoventilation. All right, question 2. A 60-year-old male with a history of obesity and untreated OHS presents with worsening dyspnea, lower extremity edema, and elevated JVP. Which of the following complications is most likely? Is it A, cor pulmonale, B, myocardial infarction, C, pulmonary embolism, or D, obstructive lung disease? I'll give you a few seconds. If you said A, cor pulmonale, you are correct. Chronic hypoxemia and hypercapnia in OHS can lead to pulmonary hypertension and subsequent right-sided heart failure or cor pulmonale. All right, I want to thank you for joining me on this episode. I really hope it helped you understand the essentials of OHS, including its causes, diagnosis, and management. Stay tuned for the next high yield topic on the Pro PA podcast. And if you found this episode helpful, hit follow and turn on notifications to stay updated. And as always, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.